Okay, let's unpack this. We've got a substantial stack of material here covering healthcare quality, data, statistics compliance, and teens.
Quite a lot to get through.
It really looks like, the foundational knowledge you need to really understand how healthcare strives for excellence.
Absolutely. This isn't just a list of terms. It's more like the blueprint for ensuring high quality, safe, and efficient care delivery.
Right. Because when we talk about quality in healthcare, it's far more than just having well-meaning doctors and nurses, as crucial as they obviously are.
Oh, definitely.
The sources make it clear it's about robust systems, it's about leveraging data effectively, and it's about a continuous, determined effort to improve.
Precisely. The Institute of Medicine, now part of the National Academy of Medicine, offers a definition that cuts right to the core. Achieving desired outcomes consistent with current professional knowledge.
Consistent with current knowledge.
It's care rooted in evidence, delivered with competence and respect, and driven by committed leadership.
So our mission for this deep dive is to take this mix of definitions, concepts, data examples, regulatory info, and frameworks, essentially, the nuts and bolts you've provided,
Always pieces.
and connect them for you. We want to reveal the insights within these pages and, well, give you a shortcut to navigating this complex landscape, making it engaging and actionable.
It's about moving beyond what these concepts are to understanding why they matter and how they fit together in the real world of patient care.
Exactly. Let's dive in.
Okay. So, to build our understanding, we start with the fundamental question. What does quality truly mean in healthcare? Beyond that IOM definition we mentioned, the material emphasizes doing the right things right.
Doing the right things right. I like that phrase. It captures, it's standardizing care based on the best evidence available, but it's also about meeting patient expectations, right?
Exactly. And a core insight here is that for quality to be managed and improved, it must be measurable.
Measurable.
Can you quantify adherence to predefined standards? That's where the foundation of data becomes essential. You need numbers.
Got it. And the sources list several key dimensions that make up this idea of quality. We're looking at things like appropriateness, availability, competency, continuity, effectiveness, efficiency, safety, timeliness, and respect and caring. Quite a list.
It is. Each dimension adds a layer to the picture, doesn't it?
Yeah.
Think about availability. Telehealth wasn't always a mainstream option, but expanding it improves access, enhancing availability.
Good example.
Or safety medication reconciliation is a system designed specifically to catch potentially harmful errors. And respecting caring, notably, is highlighted as being heavily dependent on the patient's subjective experience, what they feel.
Which makes perfect sense. The patient perspective is central to how we measure quality. Now, while we strive for these dimensions, the sources also highlight the stark reality of the cost of poor quality.
Oh, it's immense.
Yeah.
And multifaceted. It's not just about financial losses, though those are significant.
Right.
It's reduced patient and staff satisfaction. It's litigation. There are actually complex models just to calculate this hidden cost.
Wow. And this connects directly to a term mentioned, iatrogenic illness.
Yes, this is illness or harm that's caused by medical treatment or a healthcare intervention itself. It's a critical and frankly sobering reminder of exactly what quality improvement efforts are trying to prevent.
Yeah, that underscores the high stakes involved.
Definitely.
That is a powerful point. Another core concept the sources emphasize is the problem of variability.
Ah, yes, variability. Uncontrolled variability in healthcare processes is, as the material suggests, an enemy of consistent quality.
How so?
Well, think about two patients with the same condition receiving vastly different care or experiencing wildly different wait times. Understanding and managing that variation is fundamental, and that's where statistical tools really come into play.
Okay, statistics to manage variation. Speaking of recognizing problems and the need for systemic approaches, the sources reference a historical turning point. The 1999 IOM report, To Err is Human, that report was a massive wake-up call, wasn't it?
It absolutely was a bombshell, really. It brought into sharp focus the scale of preventable patient injuries, citing figures close to 90,000 per year.
90,000 injuries.
But a key insight from that report, reiterated in the sources, is the shift from blaming individuals to recognizing that systems are often the root cause of errors.
And that links to obstacles to building a strong safety culture, assigning blame, staff complacency, unsupportive leadership. These are clearly obstacles.
Right.
But the sources point out that placing accountability on the system itself is actually not an obstacle. It's a necessary step forward. It helps create a just culture where people feel safe to report errors so the system can learn and improve.
Precisely. Learning organizations understand that errors are often symptoms of deeper process flaws, not just individual failures. You have to look at the whole picture.
And to understand those systems and learn from them, you need robust, meaningful measures. What do the sources say makes a good quality process measure?
It must be relevant and valid. Simple as that, but crucial.
Relevant and valid meaning.
It has to track something that truly impacts quality, something that matters. And it has to measure it accurately. You can't improve what you don't measure correctly.
Relevant and valid measures, that's the starting point, which naturally leads us to the building blocks. Data, measurement, and some basic statistics.
Data. It's truly the cornerstone of healthcare quality improvement. You hear it again and again.
Yeah.
The sources emphasize that data collection and analysis are essential because they provide the evidence needed to improve outcomes, optimize efficiency, and ensure compliance. It's about taking raw observations, raw numbers, and transforming them into actionable insights that support informed decisions.
Okay, let's talk about the different types of data mentioned. This can feel a bit academic sometimes, but understanding data types is really fundamental to knowing how to analyze information correctly.
It really is.
The sources distinguish between categorical and continuous data.
Right, so categorical data places things into groups or buckets. Nominal data has no inherent order, like blood types A, B, ABO. The order doesn't matter. Ordinal data does have an order, like a pain scale from 1 to 10. 7 is worse than 4, but you don't necessarily know if the difference between 7 and 8 is exactly the same as the difference between 4 and 5. Right. There's an order, but the intervals aren't guaranteed to be equal.
Got it. So categories with or without order and continuous data, that can take on any value within a range.
Exactly. Interval data has consistent intervals, but no true zero. Temperature in Celsius or Fahrenheit is a classic example. 0 degrees doesn't mean no temperature.
Right.
Ratio data does have a true zero, meaning 0 actually means the complete absence of what's being measured. Think patient length of stay in days, or height, or weight. 0 days means no stay.
And a key point the sources imply is that knowing the data type is critical because it dictates which statistical methods you can legitimately use for analysis. You can't just use any test on any data.
Absolutely. Trying to calculate an average blood type, for example, just doesn't make sense. But you can find the most frequent one, the mode. The data type guides the math.
So how is this data actually collected in healthcare settings? What's the process?
The sources outline a pretty standard process. You start by clearly defining the purpose of the collection. Why do you need this data? And the specific population you're interested in.
Define purpose and population.
Then you establish your sampling methods. Are you gathering data from every single instance, like every patient admission, or are you taking a representative subset, a sample?
And sampling has its own challenges.
It does. A challenge noted here is high staff turnover, which can really impact data consistency if different people collect data differently over time.
That makes intuitive sense. Inconsistent staff could lead to inconsistent data points. What about timeframes for collection? When do you gather the data?
There are 3 main timeframes the sources discuss: prospective, concurrent, and retrospective.
Okay.
Prospective is collecting data before or during a study, planned in advance. Think clinical trials. Concurrent is collecting data during the process itself, like observing hand hygiene compliance in real time on the units.
Okay, concurrent and retrospective.
Retrospective is collecting data after the event has happened, typically by reviewing past records or charts, like looking back at readmission rates from last quarter.
And there's an interesting insight here. The sources mention that concurrent review, where you collect data and can intervene as something is happening, well, it can actually replace retrospective review as a process improvement strategy.
Exactly, because you're addressing issues immediately, potentially preventing problems, not just documenting them later. It enables real-time intervention and feedback. Much more dynamic.
What are the primary tools used for this data collection today? I imagine EHRs are central.
EHRs are definitely the backbone, yeah. And they're increasingly integrating data from other sources too, like patient wearables, Fitbits, smartwatches, and telehealth visits.
Right.
Mobile and web platforms are also used a lot for things like surveys, audits, or collecting patient-reported outcomes.
And automation.
Yes, automated sensors and IoT devices are emerging for collecting real-time data like patient activity levels or continuous vital signs, things like that. Less manual entry.
But collecting data is only valuable if it's good data, accurate data. This is where data validation becomes critical, right?
Absolutely crucial. Why? As the sources highlight, invalid or erroneous data leads directly to flawed analysis and incorrect conclusions. That could potentially compromise patient care decisions. You have to trust your data.
So validation ensures the data is accurate, complete, and fit for purpose. What does that involve? Techniques like scrubbing and verifying.
Yes, those are core methods. Data scrubbing means cleaning up errors, inconsistencies, duplicates. Verification involves checking against source documents or known standards.
And technology is helping here.
Definitely. The sources mention recent advances like AI algorithms being used to assist in identifying anomalies and validating data much faster.
Yeah.
And also FHIR standardization, that's the Fast Healthcare Interoperability Resources Standard, which is significantly improving data consistency across different systems, making validation easier in the first place.
FHIR, okay. So once you have validated data, how do you turn that into something truly useful? That seems like the essence of information management.
Yeah, that's the goal. The objective is singular, really,
Mm.
to support decision-making, improve processes, and ultimately enhance patient outcomes.
But it's not always easy.
No, the challenge is significant. The sources point out issues like data silos, information trapped in disparate systems that don't talk to each other. It's just sheer data overload. You can drown in data.
The DREP syndrome.
Exactly. Data rich, information poor. You have tons of data but can't extract meaningful insights from it.
Ah, the DREP syndrome. I think anyone who's worked with large data sets can relate to that.
For sure. Information systems like clinical information systems, CIS, administrative information systems, AIS, and decision support systems, DSS, are designed to combat this
Oh.
by organizing, analyzing, and presenting data in a useful format. And they're increasingly leveraging powerful tools like IBM Watson Health or Google DeepMind for sophisticated analysis. Interoperability standards, again, like FHIR, are key to breaking down those silos and connecting the systems so you get a fuller picture.
Okay, we have good, organized data. Now let's apply some basic statistics to understand it, starting with measures of central tendency. Where's the middle?
All right. These measures describe the typical or central value in your data set. We're mainly talking mean, median, and mode.
The classics. Mean is the average.
The mean is the arithmetic average, yeah.
Uh-huh.
Sum everything up, divide by the count. It's useful for things like average wait times, but the sources point out it's quite sensitive to outliers. One patient with an extremely long wait can significantly skew the average upwards, making it seem worse than typical.
Okay, so outliers can mess up the mean. What about the median?
The median is the middle value when you line all your data points up in order. Half the values are above it, half are below. It's much more robust to outliers, so it often gives a better representation of the typical value for things like patient length of stay, where you might have a few very long stays.
Median is better for skewed data.
Right.
And the mode?
The mode is simply the most frequent value in the data set. It's particularly useful for nominal data, like finding the most common diagnosis code used in a clinic, what pops up most often.
Got it. And weighted mean is used when different data points have varying importance, like in a survey.
Exactly, like weighting different components of a patient satisfaction score based on their perceived importance to the overall experience. Some questions might count more than others.
Okay, so that tells us about the center, but you also need to understand how spread out the data is. This is dispersion or variability.
Right. How clustered or spread out are the numbers? Key measures here are range, frequency distributions, standard deviation, and variance.
Range seems simple.
It is. The range is simply the difference between the maximum and minimum values. Quick to calculate, easy to understand, but it tells you very little about the data in between those extremes. Useful for a quick check, maybe? Like monitoring the variability in a patient's vital signs over a single shift.
Okay. And frequency distributions.
These are ways to organize the data to show how often different values or ranges of values occur. It immediately starts to reveal patterns. A simple frequency list shows every value and its count. A grouped frequency bundles data into intervals like 0-10 minutes wait time, 11-20 minutes, etc., which is essential for large data sets. You start to see the shape of the data.
What about standard deviation and variance? These seem fundamental in statistics.
They absolutely are. They measure the average deviation or spread of data points from the mean. Variance is the average of the square deviations, and standard deviation is just the square root of the variance, which brings it back into the original units of measurement, making it easier to interpret.
So a small standard deviation means...
It means your data points are tightly clustered around the mean, low variability, which in healthcare processes often means a more consistent, predictable process. A larger standard deviation means more spread, more variability.
And that's often less desirable in quality improvement.
Often, yes. Understanding this spread is crucial for interpreting data, and it's foundational for inferential statistics, especially when thinking about data distributions like the normal curve or bell curve. How much does the data typically bounce around the average? That tells you a lot about how predictable and consistent your process is.
Right, and consistency is often a hallmark of high quality. Predictability.
Precisely.
Now that we understand the importance of data and how to describe it, let's look at the tools used to analyze it and drive improvement. First up, visualization, making pictures out of numbers.
Data visualization is incredibly powerful because our brains are wired to see patterns visually. Charts and graphs reveal trends, comparisons, and outliers that are often invisible in tables of raw numbers.
The sources list quite a few types: run charts, control charts, histograms, Pareto charts, cause and effect diagrams, flow charts, pie charts, trend reports. Lots of options.
Yes, and modern tools like Tableau and Power BI make creating these visuals much easier and often interactive. A run chart is simple but effective. Just data plotted over time to show trends or shifts.
Like tracking infection rates month by month.
Exactly. A control chart builds on the run chart by adding statistically calculated upper and lower control limits.
Control limits, what do they tell you?
They define the expected range of normal variation in a stable process, what we call common cause variation. Seeing a data point outside these limits tells you something unusual, something specific is likely happening, special cause variation that requires investigation. Seeing points drift toward a limit might also signal a change. It helps you know when to react and when not to overreact to normal fluctuations.
That distinction is key, knowing if variation is just noise or if there's a specific problem to fix. Speaking of specific tools explained in the sources, let's look at the Ishikawa diagram, the fishbone.
Also known as the fishbone diagram, or cause and effect diagram. It's a structured brainstorming tool used to explore the potential root causes of a specific problem or effect.
How does it work?
You put the problem statement at the head of the fish and then brainstorm potential causes, organizing them into major categories along the bones. Common categories are things like people, process, equipment, materials, environment, measurement. The sources give an example like exploring long waiting times, where you'd map out potential causes related to staffing, methods, measures, materials, and equipment.
Helps organize thinking about causes. And the Pareto chart.
This tool helps you prioritize problems based on their frequency or impact. It's based on the Pareto principle, often simplified as the 80-20 rule.
80-20.
Yeah, the idea that roughly 80% of the problems or effects often come from about 20% of the causes. The chart visually displays contributors to a problem in descending order of frequency or impact, helping you identify the vital few causes to focus on for the biggest improvement.
The sources use a medication error example.
Right. A Pareto chart might reveal that the vast majority of medication errors, say 80%, are due to issues in just two areas: dosing calculations or administration procedures. That clearly shows where to focus improvement efforts first for the biggest impact. Don't waste time on the trivial many.
So Pareto tells you what are the most impactful problems, and Ishikawa helps you dig into why those problems might be happening. What about the Gantt chart? Sounds like project management.
It is. A Gantt chart is primarily a project management tool. It's used to schedule related interdependent activities and visualize their timelines, start dates, end dates, and durations. Crucially, it shows how tasks depend on each other, which is vital for managing complex quality improvement projects with multiple steps and stakeholders.
Okay, we touched on performance measures earlier: structure, process, outcome. But now that we understand data and tools, let's look at them again as components of a measurement system. The Donabedian model, right?
Yes, often referred to as the Donabedian model. These are foundational categories for measuring quality. Structure is about the resources and environment, the inputs. Things like having adequate staffing levels, the right equipment, proper facilities. Is the stage set correctly?
Structure, then process.
Process is about the activities of care being delivered, the how. Are we following evidence-based protocols like adherence to a specific protocol for inserting a central line to prevent infection? Are we doing the right things in the right way?
And outcome.
Outcome is the result of the care, what happened. This includes the patient's health status. Did they get better? Complications. Did they develop an infection? Patient satisfaction, how was their experience? And even cost. The sources highlight that outcomes management involves collaboration across the entire system to optimize these results. It brings it all back to the patient's end result.
Structure, process, outcome. A framework for thinking about measurement. Now, to really understand if differences or relationships we see in our data are meaningful and not just random chance, we use statistical significance tests. The sources mention chi-square and t-tests.
Right. These help us make inferences from our sample data about the larger population.
Yeah.
The chi-square test is used to assess if there's a statistically significant association or relationship between two categorical variables.
Categorical. Yeah.
For instance, is there a significant relationship between the type of long-term care facility a resident is in, facility A versus facility B, and whether or not they develop a pressure ulcer? Yes, no. Those variables are categories.
Okay. And the t-test.
That compares the means, the averages of continuous data between two groups. For example, is the average wait time, continuous data in Clinic A, significantly different from the average wait time in Clinic B? It tells you if the observed difference in means is likely a real difference or probably just due to random sampling variation. There are different types, like independent samples t-test comparing two separate groups or paired t-test comparing the same group at two different times.
So chi-square for associations between categories, t-test for differences in averages between groups. Regression analysis is also noted. What's that used for?
Regression analysis examines the relationship between one variable, called the dependent variable, and one or more other variables, called independent variables. It's often used for prediction,
Prediction
like predicting a patient's length of stay, dependent variable, based on factors like their age, their primary diagnosis, and the number of comorbidities they have, independent variables. The sources mentioned modern machine learning frameworks are advancing this beyond simple linear relationships, allowing for more complex modeling.
Okay, prediction and understanding relationships between variables. Before we shift gears to how we actually drive change, let's look at one more specific application of these metrics and data from the sources. Evaluating diagnostic tests. This seems critical.
It's absolutely fundamental to accurate diagnosis and patient safety. We use specific metrics to understand how good a test is. The main ones mentioned are sensitivity, specificity, positive predictive value (PPV), negative predictive value (NPV), and overall accuracy.
Okay, let's break those down. Sensitivity.
Sensitivity is the true positive rate. It measures how well the test correctly identifies people who actually have the condition. A high sensitivity test is good at finding the cases. It has few false negatives. Think of it like casting a wide net.
So high sensitivity is crucial for screening tests,
Right.
where you really don't want to miss a case, right? Missing a case could be bad.
Exactly. You want to catch everyone who might have the disease. Specificity, on the other hand, is the true negative rate.
True negative.
It measures how well the test correctly identifies people who do not have the condition. A high specificity test is good at ruling out people who are healthy. It has few false positives.
And high specificity is important for confirmation tests, where a false positive could lead to unnecessary anxiety, cost, or even invasive procedures.
Precisely. You want to be sure when you tell someone they don't have the disease.
What about PPV and NPV?
PPV, positive predictive value, answers the question. If someone tests positive, what's the probability they actually have the condition? NPV, negative predictive value, answers. If someone tests negative, what's the probability they actually don't have the condition? These depend not just on the test's sensitivity and specificity, but also on how common the condition is in the population being tested.
Okay, so they give context to a positive or negative result, and accuracy is just the overall proportion of correct results.
Correct. Both true positives and true negatives divided by the total number of tests. The sources even provide an example calculation to show how you derive these figures from a 2x2 table of test results versus actual disease status.
And technology is impacting this too.
Yes, the material highlights how recent advances like AI being used to interpret medical images like mammograms are achieving very high levels of sensitivity and specificity, potentially improving diagnostic accuracy significantly. The clinical implication is clear. You choose tests strategically based on your goal: high sensitivity for initial screening, high specificity for follow-up or confirmation.
Okay, so we've covered the foundational concepts, the data needed, the statistical tools, and how to evaluate measures like diagnostic tests. How do you actually make improvements happen within an organization? That requires frameworks, effective teams, and strong leadership.
Exactly. Now we get into the doing part. Let's start with continuous improvement frameworks. The sources feature the PDCA cycle quite prominently.
Plan, Do, Check Act, or sometimes PDSA, Plan, Do, Study Act. Seems like a cornerstone.
It really is. It's presented as a simple but powerful sequential and continual cycle for testing ideas for change on a small scale, observing the results, learning, and then refining the intervention or implementing it more broadly. The sources point to studies showing its effectiveness, particularly when it's actively supported by leadership. It provides a structured way to learn and improve.
Okay, PDCA. Another model mentioned is FOCU, F-O-C-U-S.
Right. And an interesting point the material makes is that focus is often used specifically to identify and understand a problem rather than to find the solution itself.
So it comes before PDCA.
It's often used before you would initiate a PDCA cycle on a potential solution. Focus helps you find a process to improve, organize a team, clarify current knowledge, understand sources of variation, and select the improvement opportunity. It sets the stage for PDCA.
So OBCs helps you pinpoint the right issue to work on, get organized and understand it, and then PDCA helps you test and refine solutions for that specific identified problem. The sources also list other frameworks like Lean, Six Sigma, and the model for improvement. Different flavors, maybe.
Different methodologies, each with its own set of tools and emphasis, but all aimed at guiding systematic quality improvement work. Lean focuses on eliminating waste, Six Sigma on reducing defects and variation. The model for improvement uses 3 key questions plus PDCA cycles.
Frameworks provide the structure, but improvement is fundamentally driven by people working together. The sources emphasize this crucial shift from working in departmental silos to leveraging interdisciplinary teams in healthcare QI.
That shift is so important. Why?
Healthcare processes are almost always complex, and they rarely stay within the lines of a single department. Think about patient discharge. It involves doctors, nurses, pharmacists, case managers, social workers, maybe therapists.
Right.
Integrating clinical and non-clinical staff from all relevant areas into a team is essential to understand these processes holistically, identify all the potential failure points or bottlenecks, and reduce errors, like those that can happen during patient handoffs between units or departments. You need all the perspectives.
How do you even get an effective team started, according to the sources? It's not just throwing people in a room.
No, team establishment isn't casual. It requires strategic alignment. Does this team's goal fit with the organization's priorities? It requires securing necessary resources, time, data support, maybe budget, and assessing feasibility. Is this achievable?
Stakeholder engagement, too.
Yes, early engagement with all stakeholders who will be affected by the team's work or whose cooperation is needed is key for buy-in. Best practices mentioned include conducting a thorough needs assessment to really understand the problem deeply, defining diverse membership criteria to ensure all relevant perspectives and expertise are included, and establishing a formal team charter. A charter, what's in that?
The charter defines the team's purpose, its specific goals, SMART goals, specific, measurable, achievable, relevant, time-bound, the scope of its work, what's in and what's out, timelines, resources, and member roles. It's the team's roadmap. And leadership engagement from the outset is vital to give the team legitimacy and support.
And the problem statement is the bedrock of the team's work, the starting point in that charter.
Absolutely. The sources stress it must be concise, specific, and measurable. Not vague like improve communication, but specific like reduce nursing physician communication errors related to medication orders by 50% within 6 months. Tools like SWOT analysis, strengths, weaknesses, opportunities, threats, or stakeholder mapping can be helpful during the charter development process to refine that problem statement and plan.
For teams to function smoothly, they need ground rules, right? How people interact.
Essential. Ground rules foster effective dynamics, psychological safety, collaboration, and productivity. Simple rules around things like punctuality, ensuring everyone participates, active listening, respectful communication, even during disagreements, confidentiality, they set expectations for behavior.
And they work best if the team develops them.
Yes, the sources suggest these are most effective when developed collaboratively by the team members themselves early on. Gives them ownership.
The sources also briefly mention team stages like Tuckman's forming, storming, norming, performing model, just acknowledging teams evolve.
Right. Acknowledging that teams typically move through these phases: initial politeness, forming, then conflict as ideas clash, storming, resolving conflicts and setting norms, norming, and finally achieving high productivity, performing. And teams might cycle back through stages if membership changes or new challenges arise. It's not always linear.
And there are different types of QI teams listed: functional, cross-functional, clinical, operational, ad hoc, self-directed. Briefly, what's the difference?
Each type is formed for a different purpose or scope. A functional team might focus just on issues within a single department, like nursing or pharmacy. A cross-functional team, which is very common in QI, brings together members from multiple departments to address a process that spans across them, like patient discharge or surgical workflow. Clinical teams focus specifically on patient care processes. Operational teams focus on administrative or support processes. Ad hoc teams are usually temporary, formed to address a specific urgent issue. And self-directed work teams have a higher degree of autonomy in managing their own work.
Every team needs clear roles. The sources mention a leader and members.
Yeah, basic roles. The leader typically facilitates discussions, helps the team stay focused, delegates tasks, works to remove barriers the team encounters, ensures communication flows, and keeps the team's work aligned with the broader organizational goals. They're more facilitator than dictator.
And the members.
Members contribute their unique expertise, experience, and perspectives. They actively participate in discussions, data collection, analysis, testing changes, and implementing solutions. Everyone has a role to play.
And managing meetings effectively is critical for team productivity. We've all been in bad meetings.
Oh, absolutely. Meetings are essential for sharing information, making decisions, and getting feedback. But they can be a huge time sink if not run well. The sources stress the need for clear objectives defined beforehand. Targeted invitations only include people who really need to be there, a structured agenda circulated in advance, strict time management during the meeting, and clear follow-up afterwards, documented minutes with decisions made and specific assigned action items with deadlines. Without this discipline, meetings flounder.
So true. All of this team effort, the frameworks, the meetings, it relies heavily on leadership, doesn't it?
Leaders are absolutely paramount. They set the tone. They're crucial for driving the necessary cultural change and embedding performance improvement into how the organization operates. The sources highlight that leaders must genuinely believe the costs and effort associated with QI are justified. They can't just pay lip service.
And involve people.
Yes. And actively involve the individuals and teams affected by the changes to make those changes stick. A key insight from the sources is that the best way leaders communicate the value of quality is by leading by example, demonstrating their own commitment through their actions and decisions.
What are their specific roles in quality oversight mentioned in the material?
Things like overseeing the formal quality management, QM, utilization management, and risk management, RM programs. But also, crucially, aligning the quality planning and initiatives with the organization's broader strategic goals. It shouldn't be a side project. It needs to be embedded in the mission, vision, and strategic plan. And using data analytics strategically to identify priorities and track progress across the organization.
And what about specific leadership skills needed?
Communication is huge. Effective, transparent, two-way communication about quality goals, progress, and challenges. Fostering collaboration across disciplines, breaking down silos, coaching staff in QI methods, creating a culture where learning from problems, using tools like root cause analysis, RCA, is the norm, not blaming. Demonstrating a visible, unwavering commitment to quality, and even considering quality performance when selecting suppliers or partners.
The sources also touch on concepts of a learning organization. What does that involve?
Ideas like promoting personal mastery, individuals continually learning, developing a shared vision for quality that everyone buys into, and fostering team learning, creating structures where teams can share knowledge and learn from each other's successes and failures. It's all about creating an environment where continuous improvement isn't just a program you run, but part of the organizational DNA, the culture.
How do leaders ensure changes don't just fade away after the project team disbands? Sustainability seems key.
Absolutely. Leaders play a critical role here by monitoring outcomes over the long term, using real-time data dashboards, for example, and actively reinforcing the desired new behaviors and process changes through ongoing training, regular feedback, performance reviews, and recognition, making the new way the expected way. The sources also mention tools like change management software can help track the implementation and reinforcement of these changes over time.
Can even organizational structure plays a part, how things are set up?
Yes, the sources suggest that having streamlined teams and committee structures with clear reporting lines for quality initiatives can enhance efficiency and communication in driving performance improvement efforts across the organization. Less bureaucracy helps.
So frameworks provide the structure, teams are the engine, and leadership is the catalyst, providing the energy and direction. That seems like a powerful combination for driving significant change.
It is, when all those pieces work together effectively. But as you know, all of this happens within a complex external environment of compliance and regulation. You can't ignore the rules.
Which brings us neatly to our next section. Let's talk about navigating that landscape, starting with accreditation.
Right, accreditation is typically a voluntary process, though often essential for other reasons like reimbursement or reputation. It's where a healthcare organization undergoes evaluation by an independent, non-governmental agency.
Like the Joint Commission. TJC, or NCQA.
Exactly. TJC, NCQA, DNVGL are common examples mentioned. These agencies assess the organization's compliance with a set of rigorous, often nationally recognized standards. The focus is heavily on organizational systems, processes, and patient safety.
Why do organizations volunteer for this? It sounds like a lot of work.
It is a lot of work, but the sources explain it does enhance care processes and outcomes by pushing organizations to adhere to evidence-based standards and best practices. It provides an external validation of quality. Plus, one study mentioned in the sources even found that accredited hospitals actually had reduced patient mortality rates compared to non-accredited ones, so there's a potential patient benefit.
That's significant. Accreditation is also linked to credentialing and privileging providers, correct?
That's right. They are related but distinct processes. Practitioner credentialing is the process of verifying a provider's qualifications, their license, education, training, experience, and overall competency. Does this person have the right qualifications to practice?
Verifying the basics. And privileging.
Clinical privileging is the process where the healthcare organization grants permission for a specific provider, based on their verified credentials and demonstrated competence, to perform a specific set of clinical services within that organization. What procedures are they allowed to do here? The National Practitioner Data Bank, NPDB, is mentioned as a key resource. It collects data on malpractice payments and certain adverse actions related to providers, which hospitals query as part of these credentialing and privileging decisions.
Okay, so that's the voluntary side. On the mandatory side, we have regulatory bodies like CMS.
Yes, the Centers for Medicare and Medicaid Services. A major player. They oversee huge government programs like Medicare and Medicaid, and they enforce compliance through mandatory health and safety standards. These are known as the conditions of participation, COPs for hospitals, and conditions for coverage, CFCs, for other types of healthcare facilities. You have to meet these to get paid by Medicare or Medicaid.
Conditions of participation.
Ah.
COPs. And this links to the idea of deemed status. What's that?
Deemed status is an important concept. It's where CMS officially recognizes accreditation from certain approved national accrediting organizations. TJC and DNVGL are key examples cited as evidence that a hospital meets the Medicare and Medicaid COPs.
So if you're accredited by TJC, CMS essentially says, okay, we deem you to meet our standards too.
Generally, yes. It means a hospital accredited by one of these recognized bodies is deemed to meet most CMS requirements. The huge benefit is it usually reduces the need for separate, routine, comprehensive surveys directly by the state survey agencies on behalf of CMS. It streamlines the certification process and reduces the regulatory burden on the hospital.
But CMS still checks sometimes.
Oh, yes. CMS conducts its own random validation surveys on a sample of accredited hospitals to ensure that the accreditation process itself is effective and truly reflects compliance with the COPs. They keep an eye on the accreditors.
Okay, that makes sense. Let's touch on some specific key regulations mentioned in the sources. IPA, Stark Law, and the Anti-Kickback Statute. IPO is huge.
IPA, the Health Insurance Portability and Accountability Act. It's the landmark federal law protecting the privacy and security of protected health information, or PHI. It has two main parts discussed: the privacy rule and the security rule.
Privacy rule.
The privacy rule sets national standards for when PHI can be used and disclosed. It includes the important minimum necessary standard, meaning you should only use or disclose the minimum amount of PHI required to accomplish a specific permitted purpose. Don't share the whole chart if you only need the patient's name and appointment time.
Minimum necessary. And the security rule.
The security rule deals specifically with electronic PHI, ePHI. It requires organizations to implement specific administrative, physical, and technical safeguards to ensure the confidentiality, integrity, and availability of ePHI. Think passwords, encryption, access controls, facility security, disaster recovery plans.
And IPA isn't static, right? Recent updates focus on.
The sources mention an increased focus in recent years on cybersecurity threats, given the rise in data breaches. Also, enhancing patient rights regarding access to their own data and promoting interoperability, facilitating secure data sharing for a care coordination, often leveraging standards like FHIR, while still maintaining strict privacy protections.
Ethical considerations seem woven throughout IPA.
Absolutely. There's a constant balancing act between the need to use and share information for effective treatment, payment, operations, public health, or research, and the fundamental right of the patient to privacy and control over their sensitive information. Using de-identification techniques when possible is one strategy. Modern tools mentioned include things like electronic consent platforms to manage patient permissions more easily, and even AI tools designed to help organizations monitor for compliance issues.
Okay, EPA is about privacy and security. What about Stark Law and the anti-kickback statute? They sound like they address financial conflicts.
They do. They're about preventing fraud and abuse driven by financial incentives. Stark law, generally speaking, prohibits physicians from referring Medicare or Medicaid patients to entities for certain designated health services, like lab tests or imaging, if the physician or their immediate family has a financial relationship, like ownership or compensation arrangement, with that entity, unless a specific exception applies. It aims to prevent self-referral based on financial gain rather than patient need.
Okay, Stark is about self-referral. And the anti-kickback statute.
That's a broader criminal statute. It prohibits knowingly and willfully offering, paying, soliciting, or receiving any remuneration, anything of value, cash, or otherwise directly or indirectly in return for referring patients for services or arranging for services that are payable by federal health care programs like Medicare or Medicaid. It targets kickbacks for referrals.
So both are trying to ensure medical decisions are based on patient needs, not financial gain.
Exactly. There are complex laws with specific exceptions and safe harbors, but that's the core intent.
How do organizations prepare for and ensure compliance with all these standards and regulations from CMS, accreditors, APA, etc.? It seems daunting.
It is a major undertaking. The sources note that modern standards, especially from accreditors, are increasingly performance-based. They're looking not just if you have a policy, but at your actual processes, your patient outcomes, your patient safety data. They often use comparative data. How do you stack up against benchmarks or other similar organizations using standardized metrics like HEDIS for health plans or OASIS for home health?
So it's about demonstrating performance.
Right. And the sources note that compliance levels aren't always black and white. You might achieve substantial compliance or even full compliance, even if a minor standard is missed, if the organization demonstrates strong overall performance and has a good plan to address the deficiency. But readiness is key. It requires thorough planning, meticulous documentation of everything, and crucially, comprehensive staff education and training. Everyone needs to know their role.
And that staff education takes many forms, not just lectures.
Hopefully not just lectures. The sources list various methods. Sure, traditional slide presentations and printed materials have their place, but also more engaging options like interactive online learning modules, hands-on skills labs, using show-me exercises during rounds where staff actually demonstrate competence in a procedure or protocol, and conducting internal mock surveys to simulate the real thing and identify gaps proactively.
Mock surveys seem like a good way to practice. What about the actual survey process itself?
Accreditation agencies like TJC conduct surveys, often unannounced, to assess compliance firsthand. Surveyors will review documents, observe care processes, interview staff and patients. After the survey, regardless of the outcome, a crucial step highlighted in the sources is conducting an internal lessons learned debrief.
Why is that important?
To capture feedback from staff about the survey experience, analyze the findings, both strengths and weaknesses identified, celebrate successes, and develop action plans to address any deficiencies found. It's about integrating the learning back into the improvement cycle. Don't just file the report away.
Finally, related to compliance, organizational liability is mentioned. How does that fit in?
This is important in the context of quality because it holds the healthcare organization itself responsible, legally and ethically, for maintaining effective systems and processes to identify and address deficiencies in the provision of care. It reinforces the idea that quality and safety aren't solely the responsibility of individual doctors or nurses. The organization's leadership, governance, and systems bear ultimate accountability for the environment of care.
Okay, that makes sense. The organization is responsible for the system. That's a really comprehensive look at the external framework of accreditation and regulation. Now, let's try to bring it all together with some practical examples and broader context found in the sources, putting it into practice.
Good idea. Let's start with two terms frequently used in performance measurement that sometimes cause confusion: benchmark and threshold.
Benchmark versus threshold. What's the difference?
A benchmark, according to the sources, is typically an industry standard, a best practice performance level, or the performance level achieved by recognized top performers. It's something you aspire to, something to aim for. Benchmarking is the process of comparing your performance against these best practices.
Okay, benchmark is the goal, the best in class. What's a threshold?
A threshold is usually a minimum acceptable level of performance. It's the floor below which performance should not fall. It might be set by a regulatory requirement, an internal policy, or a contractual obligation.
So you might benchmark against the top 10% of hospitals nationally for infection rates, aspirational goal, while your threshold is the maximum infection rate allowed by CMS or your internal standard, minimum requirement.
Exactly. One is looking up, the other is ensuring you don't fall below a certain level. Both are useful for interpreting performance data.
When using data for comparison either against benchmarks or just other organizations, the sources emphasize the need to compare your internal data not only against itself over time's trending, but also against external data. But there are caveats, right?
Big caveats. You have to be careful to ensure you're comparing apples to apples as much as possible. Are the institutions reasonably similar in terms of size, patient population complexity, case mix, teaching status, etc.? Comparing a small rural hospital's performance on certain measures to a large urban academic medical centers might not be a fair or meaningful comparison unless you can adjust for those differences.
And using the right kind of metrics is crucial for comparison.
Absolutely. Using rate-based metrics is almost always better than using raw counts or absolute numbers for comparison across different units, time periods, or organizations.
The sources use the example of patient falls. Comparing the number of falls isn't enough.
Right. Simply comparing the total number of falls between Unit A and Unit B doesn't account for differences in how many patients they cared for, patient days, or maybe the inherent risk level of the patients on each unit. Calculating a rate, like falls per 1,000 patient days, standardizes the metric, adjusting for the volume of patients, which allows for a much more meaningful and accurate comparison of fall prevention performance.
Makes sense. Adjust for volume. Where do you get external data for these comparisons?
The sources mention using commercial benchmarking databases, like those offered by companies such as Vizient or Premier, which aggregate data from many hospitals, or using national quality indicator sets, like the National Database of Nursing Quality Indicators, NDNQI, which provide comparative data on nursing-sensitive measures.
Okay, let's look at some specific quality scenarios highlighted in the sources to see how these concepts apply. Fall prevention programs, for instance. What makes a good one?
According to the material, effective fall prevention programs should include clear criteria for assessing patient fall risk upon admission and reassessing it regularly. They need to use a standardized, validated risk assessment tool. And they must have clear criteria for conducting a thorough post-fall assessment if a fall does occur to understand why it happened.
What shouldn't be part of the clinical program criteria?
The sources specifically mentioned that reimbursement criteria should not be part of the clinical fall prevention program guidelines. The focus needs to be clinical risk and intervention, not payment rules.
How do you track if the program is working? Incident reports.
Incident reports are a key data source, yes. And the sources imply that specific data elements collected in those reports are particularly useful for analyzing fall incidents and trends. Things like the patient's location, when they fell, what activity they were doing, the time of day, the type and severity of any injury sustained. This detail helps identify patterns and target interventions.
And the actual fall prevention policy guidelines, what should they cover?
They should detail the specific interventions to be used based on risk level, the risk assessment process itself, the required frequency of reassessment, and the steps involved in the post-fall assessment. Again, the sources indicate cost of care is generally not part of the clinical policy guideline itself.
Okay, falls. Medication errors are another critical area. Big focus for safety.
Huge. The sources state plainly that a medication error is regarded legally as negligence, a failure to meet the standard of care.
What's the best way to reduce them, according to the sources?
An important insight they offer is that the single best way to reduce medication errors is adopting a mandatory double-checking practice, especially for high-risk medications, before administering drugs. Two sets of eyes.
What if there is a disagreement about why an error happened, say between pharmacy and nursing? What's the quality professional's role?
In that situation, the quality professional shouldn't take sides or assign blame. Their role, according to the sources, is to facilitate a discussion between pharmacy and nursing. Create a safe space for them to share perspectives, analyze the process together, and collaboratively identify the root cause, and assume shared responsibility for implementing corrective actions. Facilitation, not judgment.
That sounds like a crucial skill. The sources also mention hazardous medications. What makes a medication hazardous in this context?
It's defined based on risk. A medication is considered hazardous if potential exposure, like during preparation or administration, could cause adverse health effects in employees, or if the procedures required for its safe administration are unusually complex, increasing the risk of error. Requires special handling precautions.
Okay. Now, the sources provide some data, like that blood utilization table example. How might we analyze something like that?
Right. Let's say we look at the table for the month of September. We see, hypothetically, 296 units of blood were typed and cross-matched for potential transfusion, and 6 of those specific units ended up being wasted, not transfused.
Okay, 296 prepared, 6 wasted.
To analyze that, we could calculate the percentage of wasted units among those that were typed and cross-matched for September. You divide the number wasted by the total number typed and cross-matched.
So 6 divided by 296, doing quick math, that's about 0.0202027, or just over 2%.
Correct, around 2%. Now, if you were presented with options based on this data table, and one option was to investigate blood waste, that 2% figure provides direct evidence of an inefficiency that warrants further investigation. Why were those 6 units wasted? Could that be reduced? Based on the likely options provided in the source context, investigating waste would be a logical first step prompted by that calculation.
Got it. Use the data to pinpoint areas for investigation. Clinical pathways and guidelines are also discussed frequently in quality improvement. What's their main purpose?
Their primary purpose, according to the sources, is to minimize unwanted variation in patient care for specific conditions or procedures. They aim to standardize care based on best evidence.
Are guidelines and pathways the same thing?
Not exactly, though related. Guidelines are generally broader, consensus-based recommendations, often developed by national professional organizations. They synthesize evidence and provide recommendations that inform the development of pathways. Pathways are more specific, locally adapted, structured, multidisciplinary plans of care. They often map out expected care steps, interventions, and outcomes over a specific timeline, example, day 1, day 2, post-op. And crucially, pathways usually include mechanisms to track variances, deviations from the planned path, which can then be analyzed.
How are they developed?
Developing effective pathways requires interdisciplinary teams, doctors, nurses, therapists, pharmacists, etc., relevant to that condition. And they should involve pilot testing before full implementation. The whole process needs to be heavily guided by evidence-based practice, EBP. The sources even reference the Melnick hierarchy of evidence, which ranks systematic reviews and meta-analyses of randomized controlled trials as the highest level of evidence to guide practice changes like pathway development.
Evidence is key. Case management is mentioned as well as a strategy to coordinate care. How might you evaluate if case management is working effectively?
Well, organizations monitor things like rates of inappropriate referrals, timeliness of discharge planning, or delays in discharge. But the sources suggest that an additional monitor to evaluate the appropriateness and effectiveness of case management interventions could be assessing patient satisfaction with the case management services they received. Are patients feeling supported, informed, and that their needs are being addressed effectively by their case manager? That patient perspective adds valuable insight.
Patient satisfaction again. RCA and FMEA are noted as important QI tools. We touched on them briefly, but let's reiterate their purpose.
Right. Root cause analysis, RCA, is a reactive tool. It's used after an adverse event or a significant near miss has already occurred. It involves a systematic investigation to dig down past the immediate causes and identify the underlying system failures or latent conditions that allowed the event to happen, with the goal of preventing recurrence. Why did this happen?
Reactive looks backward.
And FMEA.
Failure mode and effects analysis, FMEA, is proactive. It's used before things go wrong, often when designing a new process or modifying an existing one. The team systematically identifies potential ways a process could fail, failure modes, analyzes the potential effects of each failure, estimates its likelihood and severity, and then prioritizes actions to prevent those failures from occurring in the first place. What could go wrong, and how can we stop it?
Proactive looks forward. Got it. When thinking about high-level strategic planning for a healthcare organization, the sources indicate the most important consideration is what guides the strategy. The most important consideration highlighted is understanding the organization's internal potentials and its operating environment. You have to start with a realistic assessment of your own organization's strengths, weaknesses, culture, resources, capabilities, internal potentials, and combine that with a clear understanding of the external landscape market trends, competitor actions, regulatory changes, community needs, environment. Strategy has to be grounded in that internal and external reality.
Okay. Let's broaden the lens slightly and touch on care transitions and population health, as these are major areas where quality principles are applied. Care transitions first.
Care transitions, as the name suggests, refer to the movement of patients between different healthcare settings or levels of care. It could be from a hospital stay back home, or from the hospital to a skilled nursing facility, or even between units within the same hospital.
And these transitions are risky times, right?
Very risky. Poorly managed transitions are a major cause of adverse events, medication errors, patient and family confusion, dissatisfaction, and costly hospital readmissions. Effective transitions are critical to ensure safety and continuity of care.
What makes a transition effective, according to the sources?
Several key components are emphasized. Thorough patient and family education about their condition, medications, and follow-up plan delivered in a way they understand. Seamless and timely transfer of accurate clinical information between the sending and receiving providers using tools like standardized discharge summaries, shared electronic lists like medication reconciliation lists, patient portals, or health information exchanges, HIEs.
Information transfer is key. What else?
Interdisciplinary collaboration involving everyone in the transition process, and ensuring reliable follow-up care is arranged and attended, things like scheduled follow-up appointments before discharge, using telehealth for post-discharge checks, care coordination services, and patient reminders.
What are the big challenges?
Common challenges mentioned include incomplete or inaccurate information transfer, patient difficulties accessing follow-up care, transportation cost, lack of patient or caregiver understanding, and fragmentation between different parts of the healthcare system that don't communicate well. Recent advances noted include things like AI tools being developed to summarize complex medical records quickly for transitions, and the growth of regional HIEs improving data access across different providers.
Okay, transitions are about individual patient movement. What about population health? That sounds broader.
It is. Population health shifts the focus from solely treating individual patients who seek care to improving the health outcomes and health equity of entire defined groups of people, maybe everyone in a geographic area, or all patients with diabetes in a health system.
How do you do that?
It requires analyzing health status indicators for that population, like obesity rates, smoking prevalence, vaccination coverage, cancer screening rates. And critically, it involves addressing the social determinants of health, SDOH.
SDOH, things outside the clinic walls.
Exactly. Factors like housing stability, access to healthy food, quality of education, income level, neighborhood safety, transportation, access these non-medical factors profoundly impact health outcomes, but exist outside the traditional healthcare delivery system. Population health initiatives often involve collaboration across sectors. Healthcare providers working together with public health agencies, schools, social service organizations, community groups to address these broader determinants and improve health for the whole population.
A much bigger picture approach. Finally, management information systems, MIS, are brought up again in the context of data use. What's their main job?
The principal purpose of management information systems in healthcare, according to the sources, is fundamentally to provide information that supports management decisions. That's their core function.
So they're not just databases. No, they're more than just repositories of raw data or operating manuals. They are designed to collect, process, analyze, and present data in a way that helps managers and leaders monitor performance, identify problems, allocate resources, plan strategically, and make better-informed choices. The output is geared towards decision-making.
And there's a practical tip related to visualizing data from MIS.
Yes, a small but important practical note. Prior to plotting a line graph, say, to show a trend from MIS data over time, the sources point out you must first clearly define the axis measurements. What does the y-axis represent? What are the units? What does the x-axis represent? What's the timescale? Sounds basic, but getting the axis wrong makes the graph meaningless or misleading. Essential for accurate visualization.
That is practical advice, bringing it right back to the careful mechanics of using data correctly. Wow. We have covered a tremendous amount of ground in this deep dive.
We really have. We've journeyed from the fundamental definitions and dimensions of healthcare quality, recognizing the absolute necessity of reliable data, through the practical tools used for analysis and improvement, from basic stats to things like control charts and fishbone diagrams. We explored the critical role of effective teams and committed leadership in actually driving change using frameworks like PDCA.
Yeah, the human element.
And we navigated the essential external framework of compliance, regulation, and accreditation that governs it all. IAPA, CMS, TJC.
It feels like this deep dive has really illuminated the intricate, multi-layered, interconnected system that healthcare employs in its continuous effort to get better, to improve patient outcomes, enhance safety, and operate more efficiently.
I think so. We've seen how raw data gets transformed into actionable information, how collaborative teams apply structured frameworks to tackle complex problems, and how leaders need to embed quality into the very fabric of the organization.
All while navigating that complex web of standards and laws we just discussed.
Exactly. So if we were to boil it down, key takeaways really include the non-negotiable requirement for data-driven decisions in modern healthcare quality.
Can't guess anymore.
The sheer power of interdisciplinary teams when they're well-led and well-supported. The fundamental importance of understanding and adhering to the regulatory environment. And underlying it all, that pervasive culture of continuous improvement, that constant striving to do better, embodied by various frameworks and tools.
It's clearly a field that's dynamic and constantly evolving. We saw mentions of new technologies like AI and interoperability standards like FHIR integrated throughout the concepts presented in these sources. It's not standing still.
Not at all. And it leads to a very interesting question to consider as we wrap up, something maybe for you, the listener, to think about. Given this increasing reliance on data, on metrics, on technology like AI, on standardized processes and pathways in healthcare, all the things we've discussed, how do we, as both patients and professionals interacting with the system, ensure that the fundamental human element of care, the empathy, the trust, the understanding of individualized needs and preferences, how do we ensure that that remains genuinely at the heart of these increasingly data-driven and systematized approaches to delivering healthcare?
That's a profound question. Are the systems we're building to measure and improve quality inadvertently pushing out some of the essential human connection? Or can they enhance it? That's definitely something to mull over. Think about that the next time you experience healthcare, whether as a patient or a provider. Are the metrics and the systems truly capturing and supporting what matters most in that human interaction?